Hello, and welcome to today's Office of Behavioral and Social Sciences Research Training in Advanced Data Analytics webinar. I'm Elizabeth Janexi, and on behalf of OBSSR and the NIH and all of our panelists today, I would like to thank you for attending. This is the inaugural TADA-BSSR webinar. Starting in January, we are planning to host a webinar every other month. This virtual lecture series will cover advanced data analytics and data science underlying modern behavioral and social sciences research with presentations from experts showing the basics of data management, representation, computation, statistical inference, data modeling, causal inference, and various other topics relevant to big data and teaching for the behavioral and social science researchers. The presentations are going to be streamed live on Zoom and recorded and archived on our YouTube channel. So please stay tuned for an exciting lineup of speakers and topics to come in 2021. Our next webinar is scheduled for January 21st, if you want to put it on your calendar. Next slide. Before we begin, here are a few logistical announcements. Today's webinar is being recorded. All participants will be muted during the webinar. Questions and comments can be submitted via the Zoom chat feature. You can ask your questions at any time. Just click on the chat, type your questions for everyone to see, and hit send. My OBSSR colleague, Dr. Dana Schlosser, will be helping us to sort and monitor the questions in the chat for the Q&A portion of the webinar at the end. We'll do our best to answer as many of your questions as we possibly can. Next slide. Today's webinar is titled, Analyzing Complex Behavioral, Social, and Population Health Data for COVID-19 and New Opportunities for Behavioral and Social Science Research Data Science Training. This session is going to feature a brief introduction of the new NIH OBSSR sponsored training program and highlight some of the exciting ongoing research involving complex data related to the COVID-19 pandemic. The agenda will proceed as follows. First, I'm going to present a very brief overview of the NIH OBSSR TADA-BSSR program. And next we'll hear lightning talks from 5 of the 8 TADA programs. After these lightning talks, we should have about 20 minutes for the panel to answer your questions. Please join me in welcoming our panelists for today. We have Dr. Lorraine Nelson, Associate Professor, Department of Epidemiology and Population Health, and she is at Stanford University School of Medicine. Second, we have Lance Waller. He's a professor in the Department of Biostatistics and Bioinformatics at the Rawlings School of Public Health at Emory University. Third, we have Mick Tilford. Dr. Tilford is Professor and Chair of Health Policy and Management at the University of Arkansas Medical Sciences. And we have also Dr. Lucila Ono Machado. She is a Professor of Medicine and Chair at the UC San Diego Health Department of Biomedical Informatics, and she's at UC San Diego. Finally, our last speaker is Dr. Maria Glymore, Professor of Epidemiology and Biostatistics in the School of Medicine at UC San Francisco. Next slide. So, first, I'm going to tell you a little bit about our new OBSSR training program, Training in Advanced Data Analytics for BSSR, or as we are calling it, TADA. And why did we launch this program, and what are we hoping to accomplish? I'm looking for Lance here. Okay. When I started graduate school in applied social psychology in 1992, I worked on 386 and 486 PCs that were connected to the internet with slow dial-ups. Today, our graduate students in BSSR disciplines have high-speed broadband internet access, Wi-Fi, fast portable computing, and cloud computing. Next slide. My first studies in grad school, we collected our data primarily in pencil and paper surveys, and we entered the data, hand entered it into Excel and imported it into SAS and we analyzed it on a mainframe. Well, now we have data from all wide ranges of digital sources: smartphones, wearables, sensors, GPS, cell phone data, electronic health records, social media data, high density sample complete census enumeration databases, and many more. Next slide. This dramatic transformation over the past 30 years or so has given us a whole new environment for health research. We've had a transition from a data-limited environment to data-rich environment. We've seen great advances in medical informatics and electronic health records and big data analytics. And we now have vast troves of rich data that's ready to analyze or ready to wrangle. And we've got sources of public administrative data, all kinds of data that could be used by behavioral and social scientists for research. Next slide. While the ability to collect and analyze massive amounts of complex data has transformed fields such as the natural sciences, physics, and others, progress in the behavioral and social sciences has been relatively slower. Next slide. At the NIH, our scientific colleagues with research portfolios in biology and neuroscience have made great strides in applying approaches that were adopted earlier by physics and the natural sciences, but still, BSSR has lagged by comparison. Next slide. Part of the reason for this lag in uptake is that the methodology courses in most US behavioral and social sciences doctoral programs has remained essentially unchanged for the last 4 decades. OBSSR, where I work at the NIH, we decided to set out to see if we could try to begin to change that by re-envisioning doctoral training. Next slide. If you see on the left side, I sort of took this slide that was given by Dr. Kaplan, who was a prior director of OBSSR, and I tweaked it a little bit. But most of the current curriculum, which has been around for the past 20, 30 years, has focused on training professors in a disciplinary way, and the methodology has focused traditionally on small sample, null hypothesis testing, non-harmonized measures, and primarily frequentist inference techniques. We see that we don't want to eliminate what people currently do, but we want to add some of the things that are missing. We need to train our students for a range of job opportunities and prepare them to work in teams. Multidisciplinary work is really important in the kind of big data work we want to do. We need a broader toolbox of methods: big data, data science measures, harmonized measures, data linkages, curation, pattern recognition, machine learning, computational methods, and other ways of doing inference: causal inference, Bayesian inference. Next slide. So we put together an RFA back in 2019, and it focused on funding new training programs for this very purpose. If you want to read all the details, if you go to the link that I've provided here, or if you drop NIH RFA-OD-19-011 into Google, it'll bring it up for you and you can read all of the details. Since I don't have time to go through it all today, I'm just going to hit the highlights. Next slide. This is a new program that is focused on innovative computational or data science analytic approaches and their incorporation into the training for the future BSSR health research workforce. The vision of the program is that we would develop a cohort of specialized pre-doc candidates who possess advanced competencies in data science analytics so they could apply it to an increasing landscape of behavioral and social science big data. Next slide. Instead of focusing on the type of analytics we wanted them to learn, the RFA specified 3 broad categories of data that we think are ripe for use in behavioral and social sciences research. And we asked the training programs to develop curricula and ways of training their students to deal with data just like this: intensive or voluminous longitudinal data, internet data, administrative data, as well as high-density, large sample or population-level agency databases. Next slide. And my final slide here gives you a snapshot of the titles and the people and the places where we awarded all of these brand new training programs. We are going to hear from 5 of these sites today. And in the folks that are on the call are going to talk about some examples of the complex data that they have and how it weaves into their training programs. And at the end of the presentations, you'll be able to ask the panel anything about the content of their presentations on COVID-19 and or anything about the kind of nitty-gritty details about their new training programs. Next slide. So now, without further ado, I would like to begin our panel. So our first speaker is going to be Laureen. So if you can go ahead and unmute and show your video, and you can take it away as soon as you're ready.
Okay, thank you. Well, welcome everyone. My lightning talk is about the California COVID-19 public health data ecosystem. This is a project funded and supported by Google Cloud, who is provisioning us at Stanford University with a team of 12 Google Cloud engineers who will build a data ecosystem and visualization platform for all 58 California counties in our population of about 39 million people. So we're really grateful for this substantial support from Google Cloud and the participation of the public health departments in helping us build this platform. Next slide. So this being a lightning talk, I'll quickly progress through these 4 points. Our vision for this platform recognizes the fact that factors related to social determinants of health are very strong predictors of the risk of SARS-CoV-2 infection. And it also recognizes the fact that the management of the COVID pandemic is by the local public health departments in the greater than 3,000 US counties. And furthermore, recognizes that most of the data and data systems set up to date stop at the county level, at the level of a county's rates or mortality rates or whatever. And certainly very important work on the part of modelers to determine how rates are responding to shelter in place and other such policies. But the important fact is that for public health departments that are on the front line of managing the pandemic, they really need to see what's happening within their counties, and they need sub-county data to inform that. Next slide. So this slide shows the state of California, which has the 58 counties, extreme variability in COVID-19 rates. Right uppermost county not even had a single case until recently, and other counties such as LA County and others having had high COVID rates. So the needs of these counties with respect to their data needs and so on may vary widely. The population size of these counties varies. About 9 counties comprised of more than 1 million residents. LA County has 10 million residents, and about 25 counties with less than 100,000 residents, but 24 counties having hundreds of thousands of residents, but a very relatively weak data infrastructure to support the decisions they need to make on a daily basis. Next slide. So our goal is to build, and we are building, an integrated platform with rich population data, social determinants of health data that can be accessed, visualized, and analyzed by a variety of stakeholders, including the public health departments within California, as well as Stanford and other researchers. So people with diverse disciplinary perspectives that can obtain near real-time data-based insights on how to manage the pandemic. So there's many possible use cases of this platform, but 2 obvious ones are to apply advanced data science methods, to identify the sociodemographic factors associated with risk of infection in these California counties, identify the geographic hotspots, and develop predictive models for SARS-CoV-2 infection. Next slide. So the platform features I can't get into very deeply on a 5-minute lightning talk, but Google Cloud is building this platform on BigQuery. It's highly secure, so it can be used as a tool for public health decision making. The platform will be available to all the public health departments in the state, and with free sort of access to the data visualization software called Looker, which is a very advanced kind of software. It has the ability to ingest and represent many heterogeneous data sources and inputs, and with sort of nested levels of geographic detail. Next slide. So this is just a pictorial showing that if you have rich sub-county data level data, on these various features, and you join that with information on COVID incidence, mortality, case positivity rate, and so on, that you will have very rich data for really contextualizing the pandemic in each of the counties. Next slide. So we don't have time to linger here very long, but I'll just say that the data in this platform consists not only of data that characterizes the underlying population that's relatively constant, such as census and ACS data, but also the very rich data that California Department of Health has, and Department of Education, Environmental, California EPA, and so on, as well as survey data down to the district level, or the census tract level, other data related to food insecurity, and even crowdsourced data such as SafeGraph mobility data. And then can be joined with this is the research data that we and other universities are collecting regarding SARS-CoV-2 infection case rates and antibody positivity data, as well as population-based samples to examine the non-sort of medical effects of COVID in vulnerable groups. So the public health departments have the option of sharing very detailed data under a business associate agreement, or something less so at the beginning if they're less comfortable with that. Next slide. So the use cases for this platform are, as I mentioned, sort of general public health monitoring, identifying hotspots, identifying the contextual factors associated with risk, also making resource decisions about testing pop-up locations, which places maybe should be a priority for at-home testing. One of our other studies at Stanford is a in-home test kit protocol where we can recruit people using population-based methods such as address-based sampling, and then mail them test kits that they can administer at home for SARS-CoV-2 infection, have them return to a laboratory and get their results without leaving their home. This kind of thing is very important for people in essential occupations that may not have time to get to clinics for testing. This kind of data resource that we are setting up is also important for policy decision making regarding school opening, business reopening, and importantly, to be able to develop and tailor community interventions to reduce the spread of SARS-CoV-2 or to ameliorate its adverse effects. Next slide. So this is just a slide from a group in Texas that has done a wonderful job in the city of Dallas, collecting and linking these kinds of data, such as I just described, to the SARS rates, the COVID rates in the county. So just showing that they actually developed a specific vulnerability index for COVID that consists of comorbidity rates such as hypertension, cancer, diabetes, and so on, the density of the population over age 65, and social deprivation measures such as lack of access to food, medicine, employment, and transportation, as well as mobility data modeling the rate at which the individuals are able to observe stay-at-home and social distancing measures. So they showed in a proof of concept that this index has a very, very strong correlation with COVID risk. Next slide. So just to finish up with the fact that in California, we have a very proactive governor who is linking the decisions about how to open to less restrictive levels each county, and it's based on a health equity index that came into effect October 6th of 2020, and is based kind of on the adjusted case rate as well as the test positivity rate in each county. So this means that each of the counties will, and they do now, have to report these measures, and they have to be able to say how it is they're collecting data and ameliorating the spread of the disease in their counties. So a resource such as we have will really enable them to do that much better than they are able to do on their own. Most of these public health department employees have been sequestered into emergency operations centers, and they don't even have time to deal with their data needs. So they really do need help. I'll just end with the last slide, which is just showing that this is actually slide after that, I guess. Yes, thank you. So this is just showing that there's each week these tier assignments are reassessed, and there's policy decisions about whether people can move to less restrictive or more restrictive areas, policies in terms of opening up the population for movement. Thank you.
So Lance, if you would unmute and turn your video on, you're up next. And the participants are reminded to put their questions in the chat.
Great, thanks. I'm representing both Hannah Cooper and myself as the leads of the Emory TADA site. Ours focuses on drug-related harms, which may not directly relate to COVID, but the use of data and being able to quickly respond to what's available and doing what you can with it this is an example of some of the work we're doing here. So if we could check next slide, please. As a GIS and spatial statistician, and those of you out there who work, which is probably most of us, with social determinants of health, we're all very convinced that where you are can determine what happens to you. Your zip code and your genetic code are two things that play, but what's around you provides context for the risks you're up against. With COVID-19, we're well aware of racial differences are well documented in incidence and spread. A lot of people have been asking about, what about testing deserts? Are there spaces where we're not testing people? Where are the blind spots in our testing pattern? And that's what we're trying to do. So I'll give you a quick example with one map, and that'll be the end of my presentation. But a couple of things to keep in mind: consolidated testing site data is very hard to come by. It's not run by a single location. It's, CVS, they're national firms that do it. Your state health department will be doing it. Your employers may be doing it. The VA may be doing it. Primary care physicians have it available. Drive-in pop-up clinics. So how to get this information is incredibly challenging because it's not really consolidated anywhere. We're working closely with our state health department, but it's always chasing down. Crowdsourced data is available through GIS Core and others where people will drive by and say, oh, I see a testing site, but it'll also be delayed in putting it in the data, and it may stay there longer than the test site is open. So I'm going to show you is one map relating to the metropolitan Atlanta area. With just population density in the background. We're mapping private, county, public partnership-based testing sites, not showing employment-based or VA clinic or primary care, but just to get a sense. This is some work that Behzad Kiani, a PhD student who's defending in 2 weeks, is putting together. So if we could have the next slide, we can take a look at the data. So we need to remember that the map in the background is data from the census. That's good sociodemographic. We could get race, we can get age, we can have some home ownership. These are block groups, so smaller than the county level. The gray boundaries are counties. Fulton and DeKalb are the central Atlanta counties. The red dots are private clinics. You can see they kind of look like site allocation for competitive businesses. They all have their own little zone around them, and they kind of cover the whole area. The county-sponsored ones in orange, this is primarily in Fulton County in the center on the left, concentrated in the center of a long county that runs kind of north and south. Then the green ones are the public-private partnerships, some sponsored by public organizations and some sponsored by charity outreach aspects. You can see these have a different pattern than the red ones. And when we're taking some statistical analysis tools from environmental justice measures of comparing exposure distribution, say for the non-Hispanic Black and non-Hispanic white population. We can take this map of the context in the background and see how it plays out. And the concern about testing deserts on where the gaps might be also needs to be put in the context of which population has access to which testing sites. The concentration of orange and green in the middle corresponds to the central Atlanta city center area, and actually has better access in terms of distance and capacity for the African American population and the white population. The Hispanic population is concentrated, and you can't see it in this map, in a relatively small area of Atlanta, unlike some other cities. And there, the access is going to be driven by one or two of these sites rather than the full colors. So we start to get a nuanced picture of this, but it also starts to point out to both our students and our researchers and our health department colleagues current gaps in data. These population numbers are from the American Community Survey 2018 release. That's as accurate as we can get, but represent a 5-year summary. So are these the numbers we need right now? They might not be. The dots are the data we can get, but are they the data we need? So it's a very dynamic situation, and these represent the clinics open in a 1-week period. So raises a lot of questions, starts to give us some answers, and helps us move to the next step. Thanks.
Thank you, Lance. Reminding everyone to put your questions into the chat. Our next speaker is Mick Tilford. You can unmute and show your video, Mick, and begin when you're ready.
Thank you, Liz. Our training program was developed in conjunction with the Arkansas Center for Health Disparities Center of Excellence, and so we called it the ArchD T32. I'm a principal investigator along with my colleague Jonathan Bona, who is an informaticist in our Department of Biomedical Informatics, and Caroline Miller keeps us moving forward. We are interested in racial disparities, and so our award came from NIMHD. Next slide. A little bit about Arkansas. We're a very poor state. We have 3 million residents total. Our average life expectancy and other health measures typically fall well below the national average. This slide is just simply to show you we have one county that has life expectancy above the national average. We have about a 10-year difference from the southeast corner to the northwest corner in life expectancy, with a very poor population in the Mississippi Delta. Next slide. Historically, we've been lagged behind the rest of the world in healthcare analytics, but thanks to our CTSA program, we've seen a steady growth in our biomedical informatics faculty. That's led to some growth in our graduate programs. We have new MS programs in a couple of places. Prior to the T32, we had no formal training program in social science, PhD programs that integrated advanced analytics. And our state really lagged behind in developing a workforce with advanced analytic skill sets. And so we're really thankful to be participating in this TADA. Next slide. A little bit about some of the data we've been using to address COVID-19 comes from our partner at the Arkansas Department of Health. They're a partner with our college and of course with our T32. The Arkansas Department of Health is structured in such a way that they do have local health departments, but all of the local health departments are controlled under one roof, headquartered in Little Rock, just next door to our College of Public Health. They've been doing contact tracing, and every case that's identified is then interviewed by a nurse. Of course, that data goes into a REDCap database. Then it's been identified and used for operational purposes amongst some of the partners. And I'll show you a little of that data and some creative use with that data. Next slide. This is just to show that everyone knows that there has been an increase in cases among people of color, and both in terms of cases, hospitalizations, and death. Arkansas has a large Marshallese population in the northwest corner. That population lives in dense housing, works in industries like chicken, poultry, and so highly at risk because of rates of obesity and diabetes. And we have much work going on in our college trying to do population health management among the Marshallese. So when this kind of information came out that they were much greater risk of cases and hospitalizations associated with COVID-19, it set off some alarm bells. Next slide. You also see that, in just looking at outcomes by, for those that were positive cases, what we know is that there's increased hospitalizations and increased deaths in people of color. So that, and again, amongst the Native Hawaiian population, the Marshallese, we see the highest rates of deaths. Next slide. So this is a slide from our other partner, Arkansas Center, one of our other partners, the Arkansas Center for Health Improvement. It's a large data policy shop. And they house our Arkansas, the all-payer claims database. And the all-payer claims database has been a central focus of a lot of research in the state as of late. What the ACI did is to use the data from the Arkansas Health Department, and we're able to link under regulatory frameworks to the APCD, and then they could use the information from the APCD to understand some of the risks of hospitalization, ICU admission, intubation, and death using the information from the APCD. So the APCD is going to be an important resource for our students going forward, and we hope to be able to find creative ways. We are currently working on creative ways to link data sets to the APC to understand different aspects of COVID-19. Next slide. Another source of data that I'm pretty proud about, I helped bring about, was what we call the Arkansas Pulse Poll. We're up over 6,000 interviews now, completed interviews. This was a random digit dial survey to create a seroprevalence poll. And what we figured, once we had them on the phone, we'd ask them about a 45-question survey and then try to get them to participate in the seroprevalence survey so that it all came from a random digit dial. But it gave us incredible information about beliefs around COVID-19 and other health indicators and food insecurity and a lot of questions. And so this is just one example, but it shows how the beliefs about masks differ by race and by age, with people of color having a greater belief in the effectiveness of masks. Next slide. And so finally, our CTS, our university participates in the National COVID Cohort Collaborative, and our data warehouse is large and growing, and is another source of great data for future research. And we are, of course, participating in N3C, and I think that will be a really useful database for understanding COVID for our students in the future. And thank you for the opportunity to present.
Thanks so much, Mick. Our next speaker is Dr. Lucila Ono Machado. You can unmute and show us your video and begin when you're ready.
Thank you. I will speak on behalf of the R2D2 consortium, that's Reliable Response Data Discovery for COVID-19 clinical consultation using patient observation, so essentially EHRs. Our program is a collaboration with San Diego State University, PI Christy Wells, as well as UCSF with PIs Eric Heckler and Dimitris Politis. So next slide, I posed a question that came up early in the pandemic, but what's the mortality of patients taking ACE2 inhibitors and other antihypertensive medications? So click again, please. You need a lot of data for that. Next slide, please. And if you break down by age, rate, race, and ethnicity, you need even more data because you're breaking up into groups. The next slide shows the group we put together to answer that question. It's over 200 hospitals, and there is a hospital in every single state of the US, as well as 2 territories, in a collaboration with a large German health system, so that we could also take a look into how we do this computing while respecting GDPR. There are almost 1 million patients tested and 20,000 hospitalizations. So with those numbers, we can feel confident that the answers will be reliable. And more than that, we can also use consult data from other patients in order to do comparisons. And we do this all without centralizing the data. So the next slide shows our website, which is available to all. It's public, COVID19questions.org. in which what you will see is we have already answered some questions. There are others in progress, and you can also ask a question. So in the next slide, it shows the page in which questions have been answered and they're tagged appropriately. And also with some disclaimers on how those data relate to adjusting for confounders and so on. So as an example, the next slide shows how you would ask a question. It's a simple form and it's open to anyone. There is vetting through our clinical colleagues, and we do answer questions that seem to be of general interest. The next slide shows what the process for doing that. So a user has a question, that question is typed in natural language. A clinical informatician reads it, a group of them vetted, and that is translated into code by a database analyst who will then distribute the code. We get the answers, check the results, do quality control, and then post the answers online, again, publicly for anyone to see. Note that no one has access to the patient data except the institutions that have taken care of that patient. All we got centrally is an aggregate of answers, and then on top of that, we aggregate from all institutions. So the next slide shows the answer to that early question: what is the mortality rate? And we can see that, contrary to what was feared, those people taking ACE inhibitors seem to have lower mortality than those not taking antihypertensive medications at all. And this is 8,000 patients from 11 institutions. The next slide shows the mortality per age, which also confirms what we already knew, that it's very high for those over 80 years old and relatively low for those who are younger than 40. The next slide shows what was could have been a surprise, but I will explain why it isn't. Hispanics or Latinx patients having a lower mortality than others. So we noticed that, of course, this is an unadjusted analysis and we need to do adjustments. So the next slide shows that we do distributed analytics across different hospitals. So while they keep the data all locally, it is possible to do multivariate analysis, also in a distributed manner. So the next slide shows the results of such analysis, and you will see when you control for age, ethnicity is no longer a differential in terms of mortality, and neither is gender, which also in isolation would indicate fewer deaths by women. So this is important because we can do all this distributed analysis without aggregating the data centrally, which could be a breach, a single point of breach, and also some institutions cannot submit data to a central repository. So the next slide shows how this works. And again, any registry or any centralized database could be a part of this network and other institutions as well. So what they do is they prepare tables that are then consulted with this distributed algorithm in order to create a multivariate analysis that is shown to be as accurate, exactly the same as if data were all centralized. So the next slide shows how we answer to this dichotomy. Is it right to share patient data when patients do not know about that and when there are additional risk of privacy breaches involved? And the other side that said it's right, is it right not to share because there's so much we can learn from this data? So our answer is we can share information, but we don't need necessarily to share patient data, and it's practical and it is accurate. We invite others to join the effort, and for details, we have a preprint in medRxiv. You just search R2D2 and you will find us. So the next slide, you just want to acknowledge the multiple institutions involved. There are 2 more coming up, and the role of trainees in all this effort. So at UC San Diego, we have trainees from our T15 training program participating, and soon enough, we expect to have those from the T32. Thank you.
Thank you so much. We have one more panelist today, and that's Dr. Maria Gleimar. And you may unmute and show us your video and start when you're ready.
Hi, thank you. It's a pleasure to be here. So I have the pleasure of talking about the UCSF training program, which I lead with my colleagues, Dr. Eric Prather and Dr. Will Brown. And Will came up with this super clever acronym that we're still proud of for our training program called TADA-BSSR. I'm going to talk today about novel data sources for evaluating stigma and racism in the COVID pandemic. And the theme of our training program is really to address disparities, both racial ethnic disparities and disparities along other dimensions, including socioeconomic status and gender identity, geography, and so forth. But we're going to focus today on racism. We can go to the next slide. It's been known for quite a long time that we have major racial disparities in many, many dimensions of health, and that racism plays a critical role in explaining these disparities. One of the major challenges in research on racism in health has been the challenges of measuring racism at its multiple levels. Of course, racism is often concealed and intentionally or because it's institutionalized in a way that's not explicit. But we are really excited about the potential for new data sources to create opportunities to evaluate how racism is influencing health and how changes in racism may be important for improving health and reducing health disparities. We can go to the next slide. And I'm going to talk today about work led by Dr. Tu Nguyen, who is formerly a postdoc, now an assistant professor in the Department of Family and Community Medicine at UCSF. This is a spinoff of her R00 grant that was sponsored by NIMHD on place-level discrimination and birth outcomes. But like every good social epidemiologist is now also addressing disparities in COVID. So this project her larger project is related to whether we can use Twitter data to really characterize racial sentiments and racial hostility. And one of the things that I want to highlight about this project is that I think is really nifty about the project as a whole is really bringing together big data approaches, really innovative analytics and data sources with more qualitative, contextual understanding of what the data mean. So this is a mixed methods evaluation of whether the prevalence of anti-Asian sentiment expressed in tweets increased with the emergence of COVID. And I realize I don't have the citation on there, but this paper was actually very recently published, so I can give people the citation if they'd like in the chat. Next slide. So what Tu did was pull down millions of tweets and characterize millions of tweets that referred to Asians in some way, and there's a list of words to pull the Asian-related tweets, apply a natural language processing algorithm to identify the sentiment, whether it was positive or negative, and evaluate how that sentiment changed over time. And what you can see is that starting from 2019, you have a lot of stability in the overall negative level of negative sentiment. And basically early in 2020, around the time of the epidemic, you see this spike that goes up. Next slide. Just to give those more specific numbers, you can see the first row is tweets related to Asians, and the second row is particularly tweets referring to terms related to Chinese people. And what you can see is a pretty stable level of negative sentiment. And then go on to the next slide. Starting in late February, a real spike in the level of antagonism. And we can go to the next slide, please. Again, I think that one of the interesting things was applying the qualitative research to these after we'd done this pretty intensive analytics to try to look at these in a more qualitative fashion and categorize the themes in the tweets. And you can see some of them were really explicit racism, but there was also some anti-racism in responses as some of the, there was a national recognition of what some of the issues were going to be. Of course, daily life, there was some misinformation, news, politics, and some calls for action. And I find this work, I've been working with Tu on this project for some years, and I find it really amazing to actually look at some of the text of the tweets. And so we'll go to the next slide. I had a little bit of mixed feeling about showing these tweets, but I just think it really brings home what a powerful source of information Twitter is, because people express sentiments on Twitter that they would not express necessarily in public. In sort of normal, for example, in survey settings where we might otherwise try to assess racist sentiments. So I just want to warn that there's some offensive language. So we can go on to the next slide. These are examples of direct tweets. I won't read them. I will just say that one colleague noted that two should get some award for having the most obscenities in academic publications of any than is typical in academic publications. So these are examples of tweets that follow along racist themes or blame themes. And we can go to the next slide. And these are also, they're also, of course, tweets that relate to anti-racist expressions of anti-racism and really resistance. We can go to the next slide. So that is one example of a project that I think illustrates the power of these new data sources to answer questions that we had a really challenging time getting handle on in the past. And I think that this is just one of a whole array of opportunities to do better at understanding the drivers of health disparities and do better at understanding opportunities to intervene on health disparities. There's so much COVID research going on here. It's actually been a little bit challenging to summarize it, but just to give some examples, there's really exciting work being led by the Epi Department Chair, Dr. Kirsten Bimmons-Domingo, and one of our alumni, Dr. Yehang Chen, on time trends in racial ethnic disparities and excess mortality, both among people diagnosed with COVID-19 and people without COVID-19 diagnoses, and linking those to some of the socioeconomic and racial mechanisms, so occupational characteristics, led by several of our postdocs who are just awesome postdoctoral fellows. Dr. Yulin Xuan, who is an assistant professor, is leading work on a COVID seeker app to track mobility data and link it to exposure hotspots. There are multiple Facebook-based surveys, which I think has been a wonderful opportunity to see how quickly we could get into the field with Facebook-based assessments. Dr. Nadia Diamond-Smith actually had been leading work on gender inequality in India and was able to very quickly field a large Facebook survey that will be longitudinal, assessing how the lockdown and the pandemic were affecting women of childbearing age. They're clearly a vulnerable population. And there's a lot of citizen science work with these. I think we previously mentioned the data sources led by Dr. Pletcher that are really Eureka-based platforms pulling in citizen science information. We can go to the next slide. And I will stop there and just say, here's the link to our training program. We've really encouraged folks to reach out with questions and check out the program. I want to thank my fabulous colleagues, Dr. Eric Prather and Dr. Will Brown, who are wonderful MPIs. And overall, this network of training programs is just so nifty and has been so exciting. So I hope people who are listening will look into the opportunities there. Thank you.
Awesome, thank you. I'd like to give everyone a round of applause, even though we can't hear it. That was a great little snapshot of some of the exciting work that's happening at 5 of our 8 training programs. So Dr. Schlosser and my colleague Dr. Schlosser has been monitoring the chat, and maybe you can start from the top and give us maybe a question for our panelists.
Sure. Actually, I'm going to start with a quick question for you, Liz. There was a question if international students can be involved in these T32.
Right. So for those of you who may know, the NIH T32 is a type of grant mechanism that supports essentially the stipend and training costs of students who are enrolled in particular institutions. So the first thing to say is that in order to be supported by one of these programs, you need to get in touch with one of these faculty and you need to apply to their universities and be admitted to their programs. So that's one thing. In general, the T32 does have a citizenship requirement, however, so individuals that get trained at the institutions need to be a citizen, or they could be a non-citizen national of the United States. So, and those determinations can be worked out at the institution level with the Office of Sponsored Programs at that institution. So usually the NIH doesn't help pick the participants. It's the faculty and the institutions that do that. So hopefully that answers your question, but students themselves can't apply directly to me or to the NIH to get these. And if any other panelists want to chime in on that topic, they may.
I'd like to say just at UCSF, of course, the T32 is specifically for U.S. citizens and permanent residents, but we really conceptualize this T32 as kindling a whole bunch of related research and training efforts. And we are excited about this project because it's really a nucleus of energy and training efforts. And so we encourage, and we have international students in the PhD program, and we support all of our students one way or another. So we encourage students who are excited about this, regardless of citizenship status, to apply to the PhD program. And we create opportunities for people to be involved in this type of research.
Yeah, this is Lucilla. I just wanted to emphasize that resources created because of the T32 will be used by all students. So it's a great way to contribute to international training without direct funding to the student.
Next question, Dana.
Sure, the next one is to Lori, and it's a logistical question. How will the data be accessible, when, and will it also be available for research other than COVID-19 related?
Right, thank you so much. We're building the platform now, and it won't be fully built till January. We wish it could be sooner, but it's quite involved. And it is primarily focused on the public health departments and their needs, but we're very open to talking to other researchers about research use of these data. And so you can just, I'll put my email in the chat. Anybody interested in that can email me and we can have a discussion. Thank you.
And one more quick question for you, Lori. The question is, no, I just lost that question. Oh, how is your platform different from the healthatlas.ucs.edu platform? It sounds like your platform could, the COVID data would be modeled more to small area levels.
Yes, that's true. That is what we're planning. I think I put the link, I'm a big fan of the UCSF Health Atlas, so I put the link in the chat. I encourage everybody to go see it. So that's available to everyone, and it also includes COVID data. So we have, of course, share some of many of the same data sources in our data sets, but we also have additional ones that are closer to real-time SafeGraph data, AirNow data, and so on. So I think it's just a different focus. I encourage everyone to visit UCSF Health Atlas, and I'm actually planning to speak with the leaders of that group as a result of this call. We'll have a call soon to talk about collaboration possibilities and as well. Thanks.
Okay, the next question is directed towards Mick, and it was asking about what was the belief that was measured. Was it a belief about effectiveness in offering protection, or about the health benefit or self to others?
Yes, my apologies. I put the exact question in the chat, and it was about stopping the spread of COVID-19, beliefs about stopping the spread.
That's really interesting. And I wonder, that sounds like a variable that could change over time, for sure.
We also have some really nice vaccine questions in there so that we can understand people's attitudes toward the safety and effectiveness of vaccines. And you know, the large data set can't be leaked except at the county level, but the participants in the seroprevalence study would have exact information on them, and that might be useful for some spatial analysis going down the road.
Fantastic.
Okay, the next question is for Priscilla, and this was about the automation of the platform, and Given the automation and inability to reliably adjust for confounding, isn't the platform extremely susceptible to misleading answers? And I think you clarified this, but if you could just reiterate your answer.
Yeah, I think perhaps the question came before I showed the slide in which we did adjustment for confounders and showed a multivariate logistic regression as an example of that. So I would say that any algorithm that is decomposable by site can be used that way. Hence some, I don't think the adjustment is the problem. And in fact, I think the problem is much more whether even data after being mapped are really comparable across the sites. So that's quality control that has to be continuously happening regardless of whether it's distributed or centralized.
Thank you. Now, the next question is directed towards Maria, and it's going to be a kind of a two-part question, but how were the themes or language pulled from the individual tweets for the analysis? And then also, how do you navigate Twitter bots generating tweets like these or that potential?
Yeah. So the tweets, there's a standard list of words that are race related, race or ethnicity related. And TWO's project encompasses a large set of related questions on racial prejudice. But so those words cover many different racial groups, and they include both really racist terms and sort of standard terms. There is a large training effort, so they use support vector machines to guide the natural language processing. The training tweets, there have been some training data sets already created. To also led a team to do a hand classification of several thousand tweets, which was interesting and enlightening. It turns out if you actually try to read tweets sometimes and interpret the sentiment, it's not always obvious. So we had some great students who volunteered to classify them. And then we use those as training data sets to train a natural language processing algorithm, so we can apply that very broadly on the very large Twitter data set. And then the bots, there's an algorithm to identify bots and exclude bot-based messages. It's probably not perfect, so of course there's some potential for that being a problem, but you can see certain characteristics of the bots that generate tweets.
And another question, Maria, has anyone investigated the responses to the anti-racist tweets? Are they having a positive effect or potentially increasing racist language?
You know, I saw that in the chat. That is such a great question, and I'm going to email too, because to my knowledge, we haven't done that, and I think it's a wonderful idea, and I think it's a kind of really intriguing theoretical question that we could address with these data, but I don't think we have not done that, and I don't know that other people have done it.
Okay, this is a more general question, so any of the panelists are more than happy to answer this one or give their input. A question came in that as an MPH EPI student who loves mapping, any advice or resources for starting in spatial EPI so I can eventually work on amazing projects like these?
So I put a quick response in the chat that a lot of MPH programs or schools of public health may have an elective on geographic information systems or spatial EPI. That's a good place to look. There's a lot of online information. There's a lot of good books. There's a whole range of depth you can go into. Some are focused on spatial analysis in general. Some are environmental, some are on epidemiology. I put my email address in the chat, and I'm happy to give resources. I teach the GIS and advanced GIS class and the spatial statistics class at Rollins. So I know the statistical side of that community pretty well. But as someone who thought I'd painted myself into a corner going into spatial statistics, it's heartening to see every presentation have maps involved. So I'm glad for your interest, and there's a lot of good work to do there.
Okay, Liz, that is basically the end of the questions, and we're hitting at 12:59.
Fantastic. So there were a few questions that I'll close on about how others can partake if they're not part of these programs. And there's one thing that I will say is that we're planning to do these webinars every other month starting in January. So one thing you can do is tune into these webinars, which will also be archived on our YouTube channel. The next one is slated for January 21st. You can email me if you want to make sure that I know to let you know about these. And then hopefully over time, we'll be able to come up with ways for these programs jointly to share resources and curricula and other things with you. We're still working on that piece, but stay tuned. We're trying to think creatively about that. But we really welcome everyone's attendance today and the fantastic questions. And as I mentioned, this session will be archived on YouTube, so you can go back and look at it, including all of the slides in about a week's time or so. So with that, I'd like to thank all of our panelists and my colleagues Dana and Rachel for helping with the logistical side of this. And on the behalf of NIH and OBSSR, come join us again in January. Thank you.